Good afternoon, good morning. Welcome, everyone. My name is Ryan Moser, and I'm super happy to be welcoming you to this webinar today, Crossing Perspectives, a national thought leadership series that we are launching through the National Center for Housing and Health. Today's session is particularly going to be focused on the future of housing and health. I'm hearing from my colleague that I'm having feedback. Andrew, can you confirm that the audio is okay or not from your side?
Audio sounds good for me, Ryan.
Okay, great. All right, so next slide, please, Andrew. We're going to start off with just a little bit of housekeeping. So a notice to all of you. Welcome, everyone. We do not allow screen recordings or the use of images taken from these slides. This meeting and all associated content are the property of CSH. Attendance does not grant permission to record, reproduce, distribute, publish, transcribe, scrape, or otherwise use this content. Unauthorized recording and data capture is strictly prohibited. By staying in this meeting, you agree to these terms. Sorry to have to start from that perspective, but just in response to some new things that are happening on the internet. And that said, and out of the way, I'm Ryan Moser. I'm our Vice President of Strategy External Affairs at CSH and the Center. I am excited to welcome you to this inaugural event for this new thought leadership series that we are launching on the future of housing health today and broader how systems and housing and health combine. About us, the National Center for Housing and Health is a new resource powered by CSH. It's dedicated to advancing the alignment between housing and healthcare. It's through a living resource hub that you can find on our website, the social media links that you see below. It's a place where we hope that people can learn, skill build, connect with their peers. We bring together innovation, proven models, research, and policy with practical strategies. And we seek to help partners, including housing providers, healthcare organizations, policymakers, community and systems leaders, to find what is working, learn from their peers, and put good ideas into action. If you've not checked us out, we just launched in April, and we would love to have a visit. So check out our website or join us on social media. Connect with me on LinkedIn. I'm always happy to talk to you there. So for our agenda today, I'm just going to, in a moment, pass the baton to my colleague, Nancy Egnal-Thorpe, who's going to acknowledge some partners, and then we're going to move directly into a panel discussion. Given the size of the audience, we have disabled the chat box, so we are hoping, however, to reserve some time for questions at the end. So if you have questions, you can give them to myself and Andrew. We'll be monitoring them through the Q&A function. You should see that down in the bottom of your screen. It's a little box that looks like a question mark, and you can enter your questions there, and we'll curate them as time allows for the panel to dig into at the end. All right, and without any further ado, I'm going to pass it to Nancy to take it from here.
Yes, hi, thank you. Just want to give a big shout out and thank you to our pre-launch sponsors. So we would not be here without the support that we have through our yield giving, which gave us the runway to design this thing called the center, and also to Bank of America that came in early. And then two other sponsors I want to shout out that came in pre-launch. Thank you, thank you, thank you to Amalgamated Bank and Folio Furniture. And we're open for more sponsors, so please reach out. I'll turn this over to Deb De Santis, our President and CEO.
Thank you, Nancy. I am so excited to be facilitating today's conversation with such an esteemed group of panelists who have deep practical experience that they'll be sharing with all of us today about where the field has been and where it is going. So joining us is Carmen Heredia. Carmen is a former Arizona Medicaid director who oversaw care for more than 2.5 million residents and now leads Sonora Strategy Partners, advising on Medicaid strategy and system transformation. She brings deep expertise in public sector health systems, integrated care, and nonprofit leadership, and, by the way, is a member of the CSH Board of Directors. Also joining us is Dr. Margot Kushel, who is a UCSF professor, physician, and director of leading research initiatives focused on homelessness and health, including the Benioff Homelessness and Housing Initiative. Her work centers on preventing and ending homelessness and improving health outcomes for vulnerable populations. We're also joined by Amiyoko Shabazz, who is a lived experience leader, advocate, and artist with over 20 years of advancing housing, justice, and community empowerment. They use a trauma-informed, human-centered approach to drive systems change and uplift marginalized voices nationwide. And spends a lot of time thinking about joy, which I'm really hopeful we're going to spend some time learning about. And our last panelist is Dr. Sarah Stella, who is a hospitalist at Denver Health and director of the HOPE program, where she leads cross-sector initiatives supporting people experiencing homelessness. Her work focuses on integrated care and advancing health equity for individuals with complex health needs. So I want to thank our panelists for what I'm sure will be an interesting and engaging conversation. It was important for us at CSH to have this conversation as we launched the National Center for Housing and Health to not acknowledge the unique times that we're currently living through and the myriad of growing needs and challenges in our field that our field is experiencing, including an aging population, an increase in complex care needs, state budget challenges, federal budget challenges, HR 1 implementation, a federal focus on fraud, waste, and abuse that crystallizes state priorities, a caregiver workforce shortage, something that we're looking deeply at through our national compensation study, and the obvious need for more cross-sector efforts, which I think we'll hear a lot about in today's conversation, and that need for cross-sector efforts at a time when resources are very limited. So I'm sure that our panelists will touch upon some of these challenges and others, as well as opportunities to advance the intersection of housing and health. So let's get started, and let's start with what's happening now. I'm going to ask, and probably start with you, Margot. What's the most important shift happening right now at the intersection of housing and health? And what's the most important shift happening that you're seeing in the data that perhaps the field doesn't fully appreciate yet?
Yeah, thanks so much. And I'm so happy to be here today. I think one thing that you already mentioned is if you're seeing this in the field, it isn't just your imagination. People experiencing homelessness and those living in supportive housing are actually sicker than they were a decade ago. People are aging, so we're seeing many more complex chronic disease conditions, many more early onset of what we usually think of as aging-related conditions. So more people living with dementias, living with functional deficits, people experiencing homelessness or in supportive housing with conditions like cancer and congestive heart disease that really require an integrated housing and health response. I would say particularly the data is pretty clear, and I will say particularly in the West, in the Mountain West, in the Southwest, where most people experiencing homelessness do so in unsheltered settings. We are actually seeing increases in substance use, increases in stimulant use, particularly methamphetamines, and some associated mental health, sort of an exogenous source of psychotic symptoms and other things. So people really are frailer, sicker, requiring more supports. I would say maybe some bright spots to focus on that hopefully we'll have time to address are these 1115 waivers. These are these state demonstration projects where states receive permission to do sort of innovative pilot projects to use Medicaid in innovative ways. We're seeing a lot of states, I think we're up to 23 now, using those waivers to address housing related services, paying for first and last month's rent, paying for tenancy support services, and some early signals of really promising results, even though we're facing political headwinds.
Sarah, you're working every day in the health system. How's this resonating with you, what Margot just talked about?
Yeah, I think this resonates very deeply with me and my experience as a safety net hospitalist. About 1 in 5 of the patients that I treat in the hospital are experiencing literal homelessness. And about 60% of them actually have some sort of serious functional impairment, like a cognitive impairment or a mobility impairment that interferes with their ability to access both housing and healthcare services. And so I definitely have felt over the course of my career over the last 18 years, this just significant increase in complexity and unmanaged over time. This complexity really results in higher acuity. And so we're seeing more folks with these very acute presentations in our hospital system.
Hmm. Thank you. And Carmen, so you're working on the policy side of this, and so how are policymakers responding to these trends? What are you seeing in your work?
Well, I think that there's a lot of positive momentum and some fragility as well in the policy space. The momentum is that it's recognized, right? We've been working on housing as a healthcare issue for over a decade. And as Margot mentioned, the 1115 waiver authority is now proven, not just theoretical. So since multiple states are using that as a mechanism to have some demonstration programs and creative funding opportunities, Medicaid is now being seen as a potential space to be able to intervene with housing issues and using Medicaid dollars for housing, specifically navigation, tenancy support, and maybe moving costs, for example. I was the former Medicaid director in Arizona, and there we have the H2O program, and it's now showing per member per month savings in healthcare costs. And that's exactly what we wanted to see. Another area of momentum is how managed care organizations are starting to see housing as a real financial issue, not just as a values issue. So when health plans see that their high cost members are largely unhoused and that there needs to have changes in that so that they could see our ROI and financial improvement. Then that framing is shifting. So now you're seeing Medicaid directors across the country really include housing as part of their strategic plans. And that wasn't true, 5 years ago. So this is all positive. What's fragile is that, of course, it's tenuous in terms of continuity. 1115 waivers are administratively dependent, and so um, politics and administration are going to have an impact on that. And then Medicaid dollars aren't really solving the housing shortage problem. And so that's another area that we have to tackle from a policy perspective for sure.
Amiyoko, I saw you shaking your head vigorously. I think when Sarah was talking about how this is showing up in the healthcare system. What do you want to say on this topic? I think you're still on mute, Amiyoko.
Yes, I was shaking my head. On this topic, I'm on the ground, and so I get to be with the tenants, with the clients, right? And so my eyes and my body always experiences something different, right? So what the biggest shift right now, moving towards like system alignment for on the ground, I see a major disconnect between systems. They provide and what people actually experience, right? And so the gap comes down to trust. This is what I see. Without its services, especially behavior health, the gap, it doesn't reach people even when these services are available. So you have all these services that's available that people can take advantage of to change their life and to thrive. But because we don't have trust building relationships with providers, healthcare workers, right, and behavior health, then people are not receiving the services on the ground. And therefore, they're not thriving in their housing. And that's what I'm experiencing. I think if trust isn't built first, alignment on paper, it doesn't translate into real impact. And so the real shift we need is from the process centered system to relationship centered systems. And
Interesting. That's interesting. All right. So I want us to talk about alignment, but before we do that, Amiyoko, what Margot indicated about people are frailer, people are sicker. Are you seeing that as well?
Oh, of course I see it. It's all over the place.
Yeah.
It's all over the place, with the housing first model and people having choice, when people are put into the housing, there's all kind of populations living in the housing, right? And so as in community, I get to see that with people not getting services, not wanting to help, their mental health is deteriorating.
Mm-hmm.
The answer is to use the drugs. The drugs then went from crack cocaine to fentanyl. And so therefore in their housing, with their providers, with their services, they ODing. And so I remember advocating, I say, hey, if we got people ODing, then you need to train us as regular community members to know what to do if we run into a situation like this, so we can help our community member live. And so, yes, I do see health deteriorating. I see minds gone. I don't want to shed no tears, y'all, because it's so real out here.
Yeah. Thank you for sharing that, Amiyoko. All right, so let's talk about alignment then, and what meaningful alignment really looks like, and how do we achieve meaningful alignment. And Carmen, do you want to maybe get us started on that? What are some good examples of alignment, and what policy levers are necessary to make alignment real?
Sure, thank you. I think that, first acknowledging what Amiyoko was sharing, that it's a complex thing to try to, help people, and that you need partnerships from across the healthcare spectrum. And that's what's so neat about trying to tackle all of this, bringing housing resources and healthcare together, because healthcare can bring those wraparound services, peer support models that could really help in what she was addressing, on the ground, and side by side with people, and reimbursed advocate for being able to can really expand what you're offering in communities. To your question about alignment, I think that it takes a systemic partnership. And so that needs to happen with sharing data and sharing accountability, sharing resources. One of the ways we did that in Arizona, and again, that program that I mentioned, is that the state agency was connected directly with HMIS, the Housing Management Information System, in order to be able to, launch this program and realize that shared data is the way to align. Managed care contracts are a way that you could use. You embed health outcomes that are related to housing into the managed care contracts. It makes it really important then for those health plans to perform, and it's not optional if it's in their contract. And so that's a lever that specifically Medicaid directors and states have at their disposal. And then another thing I'd add is cross-agency data infrastructure. You can't align what you can't see, so states need to build formal data sharing agreements between Medicaid and housing agencies, corrections, and HMIS. The system's chronically underfunded And we often treat data as a back office issue, but it's actually foundational to really get to outcomes and to get renewed funding. So I can't emphasize data enough, and that includes joint governance, not just MOUs, but shared decision-making structures that will really treat housing as a healthcare issue.
Are you concerned at all that there seems to be less value placed on data these days and gathering data and using data to inform real solutions?
I am concerned again because I think it's foundational for the success of a program and for renewed funding and longevity. So it's sad to hear that, and it is concerning.
Yeah, thank you. Sarah, I had the pleasure of bringing the CSH board to Denver not too long ago, and we actually, you were kind enough to give us a tour and talk about the work that you're doing there, and where I think you have a really fabulous model of integration. So as you think about the work that you're doing, how do you think about systems alignment? And maybe you could pull from some experience that you've had in Denver where you're trying to bring together both the housing system and the hospital system.
Yeah, thank you. I I really loved what Carmen said. I mean, all of this goes back to partnerships and thinking about how to partner in new ways. I think that's going to require all of us to get outside of our comfort zone and find ways to do that in a way that better serves our patients and clients. And so when I talk to folks in the community across all of our settings, we are all experiencing similar challenges, whether it's in a street outreach team, in shelters, in correctional care settings, in the hospital, in supportive housing. We're all feeling this increase in complexity, and we all have carry with us a lot of uh, distress around trying to seeing needless suffering, and people are innovating out of desperation and out of necessity. And so I think partnerships are key. And how do we have the right sort of funding models that support that really integrated work and allow us to do the things that need to happen? I think data is also hugely important, both from the standpoint of thinking about how do we identify folks for intervention, and from the standpoint of understanding the needs and the impacts of our interventions. And so I lead a team that is called the HOPE team, Housing Outreach Partnerships and Engagement team. And that is a team that really lives at the interface of Denver Health's acute care hospital and emergency department and the homelessness response system in the region. And one of the things that we've learned is the importance of data to be able to identify folks when they're in our care, effectively outreach them, and then to be able to connect them. And so Colorado's done some great pioneering work related to combining continuum of care data and Medicaid data through the statewide supportive housing expansion. And there's work happening to develop a social health information exchange. And so I think that's the direction that we're moving, and that's good because that is what we need is more transparency to be able to better serve folks.
Margot, do you want to talk about alignment and what you see with regard to, promising practices? Or do you want to pull this thread a little more on data?
Well, I mean, I think all of those things go together. I mean, you asked Carmen what policy levers, and it's sort of two things, right? It's the funding that people will ultimately follow the funding. And I think the fact that so many Medicaid systems have acknowledged the important role of housing in health, not that it's the end all and be all, but in some ways it's the basis of what we need to do, has really allowed for these innovations. And the early results, the early signals are really promising. 1115 waivers, for instance, need to be evaluated. There always some question about how well done these evaluations are, but there are some really well done ones that are showing signal that they often have an upfront investment, maybe costs go up for the first few months, and then they're seeing these great outcomes of real true reductions in acute care use and the like, which is really promising. I think that data is incredibly important for two reasons. One is it allows for the longer term research, right? To understand trends, to understand did things work or not, where do we need to make adjustments, and where are we going in the right direction. But the other really promising thing is real-time data. You see it in Los Angeles using an integrated data system, which has allowed them to improve their prediction models on who is likely to become homeless and to reach out and actually provide interventions. That's incredibly exciting and important. I do think in this new world of data models, there's some concern both in this current political environment of data being weaponized. I think it has even increased everybody's concern and privacy concerns, which are always there. But there are some really promising practices, where these statewide data mergers, California is in the process of trying to do it, that I think offer incredible promise for the future, because you can't change what you can't see. And I think it allows us to have a more honest estimation of what's going on and where do we need to make adjustments. And then I want to speak to like what Amiyoko said, which is so true. Like we can't hide from the hard things. That it does look like there is definitely signal that people being housed, not surprisingly, is beneficial for their health and likely even the mortality. But it looks like we have not seen the reductions in overdose that we would like to see. And my guess it's a combination of two things: that people use less because they're getting enrolled in MOUD or medications for opioid use disorders at a higher rate, but that the actual use could be even more dangerous because people are using without someone right next to them, with naloxone or a reversal agent to do that. But I don't think we should take that as this is how it is and how it will always be. I think we need to take that in the way that healthcare thinks about problems. And we've identified a problem, and how do we address it? And I see some really promising models of empowering peers inside PSH, really deploying harm reduction models, making naloxone really well used, really leaning into the expertise of peers, that this doesn't need to be how it will always be. And then with all of that, though, we need to face, which I think you were hinting at, we're living in sort of an evidence-free environment right now, right? There's a lot of things going on in the health space naturally that do not pay attention to data and evidence. And I think we need to really continue to speak out about the importance of following the evidence and continuous improvement.
Amiyoko, from your perspective, I think I know the answer to this based on what you said earlier, but I would love for you to talk about it a little more. Do the systems feel connected or disconnected from your perspective, the housing and the healthcare systems? And then I would love for you to just talk for a minute about the importance of peer support and how that's playing out in supportive housing or in housing. And what more should we be doing to promote peer support?
Okay. You asked me two different things.
I did.
So,
because there's so much I want to hear from you, Amiyoko.
Right. I'm so like in the conversation too. So Margot said something and it reminded me of a lived experience that recently happened. And it happened, and it's about harm reduction. Can I talk about that real quick? I
Yeah,
said,
yeah,
can I
go
talk
ahead.
about that real quick?
If you can keep it short, though,
I'll keep it
would love
short.
to hear it. Thank you.
It comes down to your peer specialist and
Yep.
community and
Awesome.
dealing with harm reduction, right? And so I know there's a community member and community that struggle with substance abuse, right? When he got herself back together, did everything she needed with the services, right? But then she had a fall down. She had a relapse, and nobody knew that she had a relapse. But the peer specialist that knows harm reduction was able to recognize it, who was the community member, and they were able to pull them to the side and say, hey, I see you was doing so good, and I just want you to know that I used to suffer from what you suffer from, and I realize how you can relapse, but I want to tell you, get back on the horse. So this is what you do.
Nice.
Call your sponsor and do you a 30 to 30, because that's how you get yourself back on track. You throw yourself in the community of support and you do your 30-30. She say, 30-30. I say, yeah, you do your 30 meetings in 30 days. And do you know, see, that was just the peer specialist that lives in the community. Nobody else might have seen it, but the peer specialist seen it. And the peer specialist was able to intervene as a kind community member. And guess what? She went back to the services to get herself back on track. And so it is important that we use peer specialists. It is important that we use lived experience to fill the gaps. And to your question, when you say fragments, yes, things are broken. Things down here are still broken, right? True alignment will feel seamlessly, and it will feel like it's human-centered support, not separate systems connected, right? Just handing people off, but true connections. I am a great believer that these relationships have to be built, right? I know that there's data. I know that everyone has their profession, but for the people that you help in, if you don't build no relationship with these people, are you really helping?
Yeah.
And building relationships is very fundamental, basic fundamentals, because they are humans. We are humans. And so I'm big on human-centered support and treating people as whole human beings, not treating them as a diagnosis or a case file, right? When the peer specialist had the engagement with the woman that relapsed, she didn't talk to her like she had a diagnosis or like she had a case number. What she did is she called her by her name and she said, come here. See, I'm the one that talked to her. It was a live, real experience to one of my community members. And the way that she smiled at me made me feel so fulfilled inside, because I was purposeful with the knowledge and the lived experience that I had. Oh yeah, I'm getting caught up.
What you're saying is really hitting a chord with me, because I think that where the real success is with it's with the housing navigators, it's with the peer support specialists, it's with the caseworkers, it's with the doctors or who are spending time with folks, right? And those are the things, when we're creating systems, building systems, refining systems, and funding systems, we often overlook just how important people are in the process, right?
I see it all the time.
Right. So that really resonated with me. So thank you for that. So let's talk about what concerns you all have about where the field is headed. And Margot, what are the warning signs or that you're seeing, or the areas of concern you have that you're seeing in the data?
I mean, I think, what we're seeing in the data is the absolute vital importance now on leaning into what we know works, leaning into viewing housing as a source of stability and safety from which everything else can be built, leaning into the fact that we need to align our health system with our housing, leaning into the fact that we need to align our payment systems with these. And I think the headwinds we're facing are things like the looming HR1, the work requirements, which are going to effectively not get any more people into effective employment, but instead are going to remove really vulnerable people from Medicaid rolls and are going to blow a big hole in state budgets and are really going to turn us back. The threats to the 1115 waivers, that there's been a signal that more will not be approved, and various rulemaking around that is pretty dangerous. The executive orders and the other signals, and everyone is trying to get through the current NOFO and understand it better, but the threats to housing first, which has been, for good reason, the standard of care, and to blame housing first on changes in homelessness, I like to say, is akin to blaming the emergency department workers for the epidemic of gun violence. It's like, you're blaming the appropriate response system for a crisis that they did not create. I think the assaults on harm reduction are going to really turn us against an incredibly well evidence-rich area that will prevent that, when it works, prevents deaths and suffering. So I think there's so much reason for optimism in a way. And I think, although point-in-time counts are very flawed, I think, when finally the early 25 AHAR, the point-in-time counts that was done in January of 2025, which of course reflected the work done in 2024, saw what looked like signals of real reductions that really pointed to all the work that had been done to align housing and health. That just came out last week. And yet, ironically, we're facing all of these real threats to what we know works that could really turn us backwards. So I think in some ways I'm optimistic after, being in this field for 30 years or so, like shouting from the rooftops, housing and healthcare are deeply connected, and finally seeing such great alignment, work in progress, but such great progress towards it. I do worry about these looming threats coming at us and how we join together and make sure we don't lose the hard-earned progress that we've made, because it would just hurt so many people and cause so much unneeded suffering and even death.
Carmen, following up on that, you want to talk about the realities of the state budgets, federal priorities, and the risks that those potential changes, pose?
Certainly, I think, healthcare, on the healthcare side, the system, the nation is changing. We're at the cusp of that with HR1, changes coming into effect pretty soon. Billions of dollars are getting subtracted from the ecosystem, right? And so there's going to be an impact in commercial health as well as public health. And this is going to impact providers and hospital systems. Everyone will feel that. And certainly participants of housing programs will feel it. So we're up to lots of change. State budgets are really, really strapped across the country. And things like the 1115 waivers, they're very administratively dependent, and CMS's appetite for participation in these kinds of programs has changed. And a lot of states that chose to include housing in their programs have opted out to not renew because of state budget restraints. So all of this leads to a lot of change. A lot is at risk from a funding perspective. The other thing we're faced with, I think, too, is workforce shortages in healthcare. And that impacts the people that, we plan to include in those wraparound services and the housing space as well. And when you have workforce shortages and funding shortages, that's really, really going to narrow the programming that's going to be available. And it's going to be, I think, very, very important to do the programs that can continue, do them well, and have really good, solid outcomes. So that, once we get through this, that we have things that we've demonstrated and change and impact and really think long term would be my hope.
Yeah, Sarah, you talked a little bit already about just, how you and your partners are, doing so much with so little. And when you think about some of the risks that Margot and Carmen touched upon, what do you fear? And I guess but then also, like, how do you think about how you're going to equip your system to deal with some of those challenges?
Yeah. I think the importance of Medicaid in maintaining one's housing and to becoming housed and going into housing with the right supports in place cannot be overstated. And so, yeah, I'm fearful. We already have situations where patients are not getting their needs met. There's a scarcity of housing and resources and appropriate supports. And it's not only a lack of affordable and available housing, it's also a lack of appropriate housing for the health needs of some of these folks that are living with very complex and acute health conditions. And so that leads to situations where people are being prematurely institutionalized, having prolonged hospitalizations, being placed in skilled nursing facilities, becoming incarcerated. And this already happens. And it's, the most expensive and least effective form of housing that exists. And so what Margot said about, we're in this moment where there's like this great alignment and there's a lot of innovation already happening, which could be scaled and funded. And then we're going to be instead looking at how do we divert our resources and our capacity within our partnerships to just help people not lose their Medicaid, which feels really hard. At the same time, I think that the relationships and the partnerships that we do have are going to be critical in mitigating the impact of that loss for folks. But I think in the short term, it's going to be really, really difficult. At the same time, I want to not have us all put our heads in the sand either, because I think there are things that we can do and plan and be ready for, and that are going to set us up and to be in a really good place when we have better state budgets and federal policies that make sense, that are evidence-based, that are focused on these long-term solutions. So I want to just encourage us not to despair, but don't put your head in the sand, even though it feels like many times that's where we're at. And I've certainly been in that place, but I think we have to keep one another from getting into that dark place.
Yeah. Do you want to talk about a couple of those things that you think we should be doing today to prepare for the future?
So we have some interesting work going on locally in Denver, where we're convening partners from health systems, from our homelessness response system, from our city, from Medicaid, and other agencies, Division of Housing, and we're thinking about what can we do now? How can we understand this? How can we look at the gaps together? How can we start to pilot solutions so that we are ready to do that? So that's one sort of local example. And then I think being at the table for these conversations. So creating tables where we have representation from people like Amiyoko, lived experience, that are truly designing interventions with us. People from the health system and the housing side, from policy. I really think we need to look at like who's at our table, who is not at our table, how can we make the right table.
Yeah. That's such an important point. Amiyoko, just so share with us, how do you set that table and make sure that you do have folks with lived experience at the table, but more importantly, not just sitting at the table, really being treated and valued as real partners in the design. So, what works, what doesn't work, and what should we know?
Well, one thing I would say, people have to listen. One thing lived experience has had a problem with is people not listening to us. We do know what we're talking about. And so sometimes lived experience, we can be right there. We'd be right there at arm reach, and they won't even reach out and touch us. And so it still boiled down to relationship building, right? Do you know lived experience, our peer specialists that's active in the community, that are community leaders, that hold the title very well? Let me tell you, I hold mine very well. That want to be at these tables, that want to use the creative mind and get into the creative thinking. Because what we have here is that, how would she say? She said something that moved me. I wrote it down. Can't find it. But you said something, I think that was Margot, right? The creative thinking in desperate times. The imagining, the dreaming, the trusting. Call me to the table. I'm coming. The invitation. Send it to me. I'm going to accept. Do that to all lived experience. Do you know how much lived experience and peer specialists have invested in getting certified and doing this field work so that what? So that we can partner with you, so that we can sit at the table with you and help you think out some of the most complex problems and help you figure it out. And so setting the table, you start with inviting the person to the table. And when they come to the table, you treat them like a human being with dignity, with respect. And guess what? Everything else gonna flow from there because we have seen each other and identified that we are human. Now, let's work in our gifts and our talents and let's do this because we can together. And I yield.
Nice. Thank you. Yeah, that's a two snap, I think, for sure. All right. So I want to make sure that we leave just a little time for a question or two from the audience. So let me give you all an opportunity to just call out both what you think is, when we think about alignment, right? System alignment, what do you think is missing? And what do we need to make sure we address in order to achieve successful alignment? So whether that's, a different partner or just how the partners currently show up, or their tools or resources, whatever you want to throw at us. And I'm just going to go from left to right on my screen. So Carmen, I'm going to ask you first.
I think probably state level planning with all the stakeholders. I think some examples are out there, but places like the center will really push out best practices. I'm so excited that this is coming from CSH and is going to be an available resource to share those best practices. What I really hope folks do is see models that are working, take that back to their state, and then create groups with all the different players, with all those different resources, and that strategically plan out the funding and the policy that's needed with people with lived experience at the table, of course. If that's happening throughout, if we're really pushing folks to participate hospitals to participate. Everybody's got a stake, and we could be so powerful if we align together and bring all those systems together.
Amiyoko.
That's how one of my relatives used to call my name. My ears moved.
I'm sorry about that. So what do you think leaders need to start doing or doing differently to move this work forward?
Identify all the leaders. Identify them. Identify all the leaders. And if you don't know all the leaders, then ask other people about the leaders. And if they don't know, ask somebody else. Identify all of them and bring them all to the table.
Nice. That makes sense. Margot?
I think we really need to make sure that our housing systems that are sort of caring for folks or permanent supportive housing have enough healthcare alignment so they can meet the needs of the people in them. We've talked about the population is aging, is frailer. There's a high level of behavioral health needs as well as physical health needs, as well as functional health needs. And I think too often our housing providers are asked to do the unattainable or the, unrealistic with where they just are not staffed appropriately. They don't have enough case management on the ground because the payment models aren't there. They don't have enough nurses or nurse practitioners or, behavioral health providers working along them because we really do know what works, but we're often not actually doing that in a way that would frankly be unacceptable within the healthcare system. In the healthcare system, we never take someone who needs the ICU or hopefully never and put them in a skilled nursing facility. Like we try to match the resources to someone's needs. So I think there's a lot of work to be done there, and that's going to come through alignments. That's going to come through the healthcare system, who frankly knows how to work with Medicaid, who knows how to re-stratify people coming to the table. I think we need to do a better job of earlier on recognizing the very few people who actually do need a more structured environment that can be realistically provided in PSH and be sure that those folks get there. But I think we also need to not prematurely do that because sometimes I think what we do is we understaff PSH and then we say it's not working when actually it would work if we actually, and then we pull people into a higher level of care, which is the most expensive, most restrictive part of our system, when actually if we were appropriately providing the staffing that people need, they could thrive in a less restrictive environment. So I think that's sort of the work ahead of us. And I think, as Sarah said, we are facing so many headwinds, but we can't give up in advance. We need to keep pushing for what we know is right. I think if we have made so much progress, like I'm old enough to have seen where we were 30 years ago and where we are now, and it's thrilling to see that we're having these conversations on the regular, that Medicaid is doing this. But I think there's much more work to do. And one of those is not only to expand our housing so that we're not leaving people out there for 10 years while they wait for a housing placement, obviously. But on top of that, we need to be better showing up as a healthcare system to allow us to match the needs as they are and to make sure that everyone can thrive and that people can thrive in the least restrictive, most humanistic system that we can do, really playing into the tremendous strengths of the residents, the peers, and the like.
Right. Sarah.
Well, that was such a great summary, Margot, and collaborators. I think I'll just wrap it up by saying, yeah, really do think that we feel very alone in this work often, and we don't need to feel that way. This is something that lots of people are struggling with across the country and in our own communities. I do feel like we need to be thinking about, how do we create an ecosystem model that allows us to use our strengths, and how do we create funding opportunities for that I think health systems especially need to be thinking about how can we, I think health systems sometimes are, sort of insular and we need to be asking our partners in supportive housing, in homelessness services, what can we be doing to support you? Sometimes we have expertise that could be important around some of these challenges with Medicaid. How can we support our partners during these really tough times? But I'm also really excited about the National Center because I think that sharing strategies, ideas, evidence with one another is going to be so important as we move forward.
All right. Well, thank you for that. And thank you all for helping us to launch the center. I think if we had a question whether or not there was a need for the center, you all answered it for us that, yeah, there is a need. And I'm very happy that we could have this conversation today. We started out by talking about this kind of the state of the land right now and what some of the challenges are. We talked about, systems alignment, what's not working and how do we improve it. And I think one of the things that I heard a lot about today was the importance of a community-wide response, a statewide response, that it can't take, one system is not going to solve the problems, and we need more people at the table. And while there are a lot of challenges in front of us, there's also a good number of things that we can point to that communities and people are doing every day that's working. And we need to continue to lift those things up. So thank you all for the conversation today. Ryan, do we have a question that we can, from the audience, that we can ask?
We have many, many questions. We're going to pick one, and it's fairly straightforward because we've got just a few minutes. So this is from an audience member. Thank you so much for the conversation. I'd love to hear from the panelists about the role they see for local government, particularly cities or towns, in strengthening connections between housing and healthcare.
Great. Margot, do you want to start?
I mean, I really think our cities and towns are really the engine of innovation, and there's so much that they can do. They often control their own data, and it's frankly easier to do that. I think that they have an incredibly important role to work with combining their nonprofit providers who are often doing the supports with their safety net healthcare systems and can really make those connections on the ground. I think that they are a space, all spaces need to follow the guidance of lived experts, but they are particularly on the ground because each community is different and those communities are the experts in their own communities. So I would say they need to be working to connect their own healthcare providers with their own housing providers and their own nonprofits. They can be combining their own data, and they should really be recognizing, uplifting, paying, compensating the true leaders in this space who are the lived experts and the peers to co-design what we need. And then I think we need to be learning. We see a great example in one community, another community that shares similarities can talk to, learn from, and try to model that. That's where innovation is going to come from. It's going to come from local community.
Yeah. Sarah?
Yeah, to just extend what Margot said a little bit. Yeah, I think cities can play a really critical role in convening and driving a lot of the innovation. And so the city of Denver has supported some of the convening of those stakeholders that I previously mentioned. And so they've been great partners for us. And I think the other thing that I think about is that we all know that homelessness doesn't stop at the county line, and that there's a great need for thinking about how do we promote collaboration across our cities and municipalities so that we have a real regional approach. So Colorado just had some legislation that was passed a few days ago and signed into law by the governor that would make it easier to remove some of the structural barriers of that kind of collaboration. So I think that's another role that cities and mayors and local governments can play.
Carmen?
I think what's been said is great. They need to lean in. Cities need to lean into solutions um, and listen to stakeholders, really get input as they make decisions. I think that, yeah, I'm thinking of some specific examples where that could have made a really big difference. And so it's such an opportunity to be at the local level, to partner with the local healthcare providers that are in the city and all the different stakeholders and really lean into the problem solving.
Okay. And Amiyoko?
I'm gonna piggyback on what Margot said because I do believe that the experts are in the community. But I want to highlight the tenant associations that's in community. And so I've started tenant associations. There's a collab with CSH that started tenant associations. So these tenant associations are the ones in community that the locals need to be able to work with because we can create our own data. We can do the research and we can create measurable outcomes.
Nice.
And
Thank
so
you.
partnership.
All right, let's give a big virtual applause for our moderator, all of our wonderful panelists. Thank you so much. I'm going to ask Marcella McGuire, our Director of Health Systems Transformation, to share one slide to show you what's next and coming up in the series.
All right. Thank you all for joining us today. Thank you for the time and the work you do every single day. Thank you to Deb as our moderator, all of our wonderful panelists. Our next session is going to focus specifically on research around housing and health. What do we know? What do we need to do? How do we learn? Please stay in touch with us via our newsletter, our website, our social media channels. I think Andrew is going to drop in the chat. If you're not already on our newsletter, please get out there. And thank you again, each for the important work you do every day, and have a great day. We look forward to seeing you. Our next session, as I said, research focused, and in July. We will be in touch. And please, if you've got interesting ideas and thoughts, please be in touch as well. Thank you all. Have a great afternoon.